We are live now. Good evening, delegates and all the participants. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for Mixed Bag webinar, organized by Dr. Ritu Santwani ma'am. So let me introduce the organizer, Dr. Ritu ma'am. Ma'am has done MBBS, MD, FICOG, FIAOG, AMRCOG. Ma'am is currently the obstetrician and gynecologist, IVF specialist, founder and CEO of 360 Degrees Healthcare Studio, and also infertility specialist. Ma'am is also a part of NUHS Singapore and also co-founder of MAAM, board member of SWWC. I welcome you, ma'am. It's my privilege to welcome the chief guest of today's webinar, Dr. Seema Pandey. Ma'am is the Director and Chief Consultant, EVA Fertility and Vanshati, Librarian of ISAR 24 to 26, Managing Committee Member, ISPAT and COM HAD 23 to 25, President of Azamgarh Ops and Gynae Society. I welcome you, ma'am.
Thank you.
Yeah. Thank you, Sahiti. Thank you, Shield Pharma, for providing the platform. From last 4 years, this program is going on. Knowledge is confidence. Knowledge always increases by sharing. With this motto, I started this series at the time of the lockdown. I can say, by the grace of my Mata Rani and by the good wishes, all those who are having a knowledge hunger, this program has gone on #1. So I'm really thankful to my dear stalwart friends. Those all are always ready to join, but getting them on the time and on the same program is not very easy. So it's always difficult to manage and get good speakers. But really, I'm thankful to them. Now we will welcome our chief guest today, Dr. Seema Pandey. Seema, a very dear friend, a very, very warm welcome to you. A very dynamic person, a very great orator. Friends, I will promise coming series, I will get Seema as a speaker. Seema, we want to hear some words from you.
Thank you so much, Dr. Ritu. And as I told you earlier, that it's been my privilege and honor to be part of this program. This program, when Dr. Ritu has started during lockdown, I've been following on LinkedIn, and I keep looking at all the stalwarts from all around the world who joined the program and a kind of the USP it has. So, as usual, I'm looking at all my dear friends who are doing excellent work in their field and they are going to talk. Without further ado, I wish this program to be on top of each and every possible
Thank you.
segment. And let's enjoy the academics.
Thank you. Thank you so much, Dr. Seema. Thank you for gracing the occasion. Friends, see, Dr. Seema is having a very tight schedule, though she was traveling to Dhaka, but still she accepted the invitation. So, Seema, I am really grateful to you. Yes, now let us welcome our guest of honor, Dr. Neelam Gupta. Dr. Neelam, are you there? Dr. Neelam? Yes, you please introduce. You please
Yes.
introduce Sayati. Warm welcome, Dr. Neelam.
Thank you. Thank you so much, Dr. Ritu.
Yeah.
I'm glad to introduce Dr. Neelam Gupta, ma'am. Ma'am has done MBBS, TGO, ICMCH. Ma'am is currently working as a medical director and consultant in gynae and obstetrics. Ma'am has many accolades to her credit. Ma'am is currently the secretary of DGF Outer Delhi, vice chairperson of Women's Doctors Wing, president of Women's Doctor Welfare Association, West Delhi. Ma'am has many awards to her credit. Scroll of Honor from Delhi Medical Association, Rashtriya Sadbhavana Gaurav Samman, and Appreciation Award from IMA Outer West Branch. I welcome you, ma'am.
Thank you. Thank you so much.
Warm welcome, dear Dr. Neelam. दुनिया के लिए वो डॉक्टर नीलम है, मेरे लिए तो मेरी नीलू है वो. So a very, very warm welcome. Yes, Neelu is very, very busy. We all know she's an Insta influencer, a very busy celebrity. So, पर वो कितनी भी
ज़्यादा हो
busy
गया.
whenever we invite us, she never says no. So, Dr. Neelam, we want to hear some words from you. Then we will start the academics.
Thank you so much, Dr. Ritu. And Dr. Shivani is here, a great friend of mine. In fact, me, Ritu, and Shivani, we all are very, very, very great friends. And Dr. Seema, hello, love you.
Love you.
And welcome everyone who's here. And
Just looking
thank you
at
so much
Shivani.
for inviting me as a guest of honor. Thank you so much, Dr. Ritu. And I'm not going to waste any more time. So let's go ahead. Thank you.
Yeah. Yeah. Warm welcome. Warm welcome. Huh. Yes, Saiti, please
Thank-
introduce all the three speakers first, one by one. Yeah.
Sure, ma'am. So let's start academics. It's my privilege to introduce the first speaker, Dr. Brajbala Tiwari, ma'am. Ma'am is the past president of Indore OBGY Society and also vice president of Indore Menopause Chapter, past vice president of IMA from 21 to 22, secretary of ISOPAP Chapter Indore, joint secretary of MP ISA 22-24, past secretary of IMA 2018 to 19. And currently, ma'am is the consultant gynecologist and infertility specialist, credential menopause practitioner, managing director of Life Care Hospital Limited, and also Santati Infertility and Test Tube Baby Center, LCH Nursing Academy. So I welcome you, ma'am.
Warm
so much.
welcome, dear Dr. Brajpala, madam. Madam
Thank
is a
you.
very excellent speaker. I have heard so many times, madam. Thank you, madam, for joining our program and gracing the occasion.
Thank
Yes,
you,
please
Dr. Ritu.
introduce our next speaker. Yeah.
Our next speaker is Dr. Shivani Sachdev. Ma'am is the director of SCI IVF Hospital, Clinical Research Fellow, Imperial College, and Hammersmith Hospital. Featured in Limca Book of Records, Founder Secretary of Delhi State Chapter Officer, General Secretary of INSTAR, General Secretary of Delhi State Chapter of ISPAT, ex-Vice President of Delhi Gynae Forum South, and also Vice Chairperson of Women Doctor Wing, IMA South Delhi. I welcome you, ma'am.
Yeah. Warm
Thank
welcome.
you so much. Thank you.
Warm welcome, dear Dr. Shivani. Shivani is known in India as Surrogacy Queen of India. तो दुनिया के लिए वो queen है, हमारे लिए हमारी शिवी है. I can say one word only. Huh? So a very, very warm welcome, a very enthusiastic person, always very keen for the knowledge sharing. So warm welcome to you, dear Dr. Shivani. Yeah, please introduce
Thank
Kiran, madam.
you.
Our third speaker is Dr. Kiran Chandana, ma'am. Ma'am has done MBBS, DGO, CIMP, FICOG. Ma'am is currently the president of Faryabad OBGY Society, member of Foxy MTP committee. Ma'am has special interest in adolescent health and contraception, active member of Foxy and Haro BGN, and contributed many articles in various journals. Ma'am has a vast experience of 35 years and currently, ma'am is the director of Chandana Medical Center, Faryabad. I welcome you, ma'am.
Thank you, ma'am.
Warm,
Thank you.
yeah, warm welcome, Kiran madam. मेरी किरण मैडम के साथ कुछ 2-3 ही मुलाकात हुई होंगी. Once I heard her lecture, she's an excellent orator. So, but the connection is like that. I always thought that whenever I get the opportunity, of course, I will invite the madam. Thank you so much, madam, for accepting the invitation. Now, without wasting the time, because I've got some messages. Dr. Seema, message आया है Dr. Sheikha from Bangladesh. Dr. Seema, it's supposed that we are going to see you in the Dhaka. देखो अभी message भी आ गया YouTube पे, हाँ? Dr. Shivani, message for you. This is from Dr. Piswan from Somalia. Dr. Shivani, once again, good to see you with Dr. Ritu. Chalo, compliment for me also. Huh? Yeah. Warm welcome to each and everyone. Yes, Brijbala madam, over to you.
Thank you so much for your kind words. And I hope I am having share screen option.
Yes.
So,
Sahiti, make them host na or co-host.
Okay, ma'am. Madam is already the co-host, ma'am. You can start sharing, ma'am.
something. Is
Yes.
it visible?
Yes, ma'am.
Yes,
You
yes,
make
yes,
it
madam.
I'm making it on slide share. So, good evening,
Okay.
everyone. And we know ovulation induction and endometrium preparation is always a matter of concern. But for me, it is and for every infertility specialist, it is the premature LSH. We are always scared of this, and we need to cancel many times cycle because of premature LSH. So I will be starting with little bit of physiology of ovulation, then LH surge and LH window, prediction of LH surge, and prevention of LH surge. So we know from our physiology day of Ganong and Guyton, this two-cell theory that HPO axis get accelerated, LH, FSH are secreted, and it acts on theca cell and granulosa cells. So we all are aware of this. So this is the two-cell, two-gonadotropin concept. Both FSH and LH are required for promoting follicular growth and differentiation. FSH works on granulosa cells, stimulating proliferation and growth of early follicular phase, thus stimulates small follicles. LH acts on theca cells and it to late follicular phase. Some LH pre-enteral stage to stimulate secretion of androgens, and then mid-follicular phase to nourish, then in late follicular phase for further growth. So the rest of the follicle goes under atresia and preventing OHSs. So before pre-ovulatory period, there is negative feedback on pituitary that happens during the childhood. So whenever there is negative feedback on pituitary, there is increased estradiol and inhibin and decrease FSH. But after puberty, there is positive feedback on pituitary and there is increase in FSH level, and this increases estradiol and it causes positive feedback and going to have LH surge. And then there is secretion of progesterone for corpus luteum and maintenance of pregnancy. So what is LH surge? During the ovulatory phase, abrupt rise in LH secretion is known as LH surge, and it starts around 14 to 27 hours after estrogen peak, and it lasts for around 48 hours, and ovulation occurs 36 hours after the surge. It is accompanied by rapid fall in estradiol level, and it triggers the resumption of meiosis, affects follicular maturation and rupture, and then cells become luteinized, and consequently a small pre-ovulatory rise in progesterone occurs within 1 hour of the LH surge completion. So this is, we have heard about this Goldilocks principle that LH has to be just right, neither too much nor too less. So LH window concept, whenever there is LH less than threshold, there will be no follicular growth and there will be inadequate endometrial proliferation. And beyond certain level, there is ceiling effect on the follicular growth and there is premature luteinization. So we need to keep LH at particular level, and ceiling effect starts from more than 5 international units. So there is large increase in LH inhibits androgen production, and this results in estradiol concentration decreases drastically before the pre-ovulatory peak. Conventionally, premature LH surge is defined as LH level more than 5 and a progesterone level more than 1 nanogram per ml. And this is the criteria for SCG administration, and it is not an uncommon problem. In the case of premature LH surge, during controlled ovarian hyperstimulation, very few follicles are retrieved from poor responders. So normal LH surge can be as high as 101, as low as 6.5, and it ranges from 2.5 to 14 times the baseline level of LH. I was always scared of kids from the beginning, and this reminds me the LH, premature LH surge. This is this Schrodinger cat will be or not. We remember that experiment that at one moment it may be or it may not be. So there may be premature LH surge or not. We are not very sure. So there is need for pituitary suppression in ART, and this is the premature LH surge. 21 to 25% is a major cause for cycle cancellation during COS. Less number of oocytes are there, reduced fertilization rate. So this premature LH surge should primarily be prevented. Now, how we can predict it? There are no fixed criteria, but there are certain things by which we can predict. It is the advanced maternal age, more than 35 whenever there is premature LH surge. High BMI, obesity is associated with premature LH surge. If high day 3 LH level on the day of antagonist administration, poor responders, PCOS, when there are many number of follicles, more number of stimulation days, and small follicles, and high estradiol or at risk of spontaneous LH surge. So there are certain scientific reports as far as this LH surge is concerned. There are three hormones: LH, progesterone, and little bit of estradiol level. So by these three we come to know, but this suggested there may be the range of LH and the level may be 180% from the 24 hours previous measurement. So, but it is the 5 to 10 international unit considered as LH surge. And this is the marker of ovulation going to happen. This one more article suggesting that advanced age is associated with premature LH surge. And this is from Frontier in Endocrinology Journal. And they found in 1021 patients underwent flexible GnRH antagonist cycle. And they found that in elderly women, there was premature LH surge, and that's why they suggested to start early antagonist, and particularly it was found in women's more than 37 years of age. And this premature rise in LH causes detrimental effect on embryonic potentials, and there are the chances of cycle cancellation. So we have to counsel the patient whenever we are taking elderly patient for stimulation. In PCOS, one more, this reproductive biomedicine journal, that this is common in PCOS patients, and there is premature LH and progesterone rise in intrauterine insemination cycle. And they found whenever there is more than 14 follicles or many small follicles, there is high risk of spontaneous LH surge. So they suggested to go for GnRH antagonist administration little earlier. Now, does premature luteinization or early LH surge is important for cycle outcome? Whenever if we are going to tell patient that we need to cancel the cycle because of the premature LH surge, but there are certain case reports when a patient were advised to cancel the cycle and patient opted to continue with the cycle. In case 1, there was serum E2 level was 918 and LH was 36. In case 2, on day 7 of stimulation, there were 13, the leading follicle was 13 and LH was 47. So they advised patient to cancel the cycle, but patient opted to continue and pregnancy occurred. So there is more precise cut threshold values are required for both LH and progesterone before advising them for cancel the cycle. So the patient can got your tongue. Patient can catch your words that you were asking to cancel the cycle. See, and we opted to continue, and it was a positive pregnancy case. So there are certain methods by which we are doing preventing premature LH surge. One is agonist cycle by down regulation, antagonist cycle by competitive blocking of GnRH receptors. So by this we prevent the premature cycles, and we all aware of the mechanism of action of agonist as well as antagonist. So I'm not going to discuss in detail. The mechanism we all know, and we know about the natural cycle LH surge, how it works, and in agonist and in antagonist cycle. One more article by Journal of Ovarian Research, and they found that LH surge without elevated progesterone level doesn't have any adverse effects on cumulative live birth. And this was done on 730 infertile women, and they found that premature LH surge had no adverse effect on pregnancy outcome if a GnRH antagonist administered as soon as premature LH surge occurred. So a transient surge could not be an indicator for cycle cancellation. It is said that Kate has 9 lives, but surge has none. So there are certain more articles. This is one of the article that you have to start early antagonist adding. So this was done on around 2096 women, and they found that initiating antagonist on ovarian stimulation day 5 rather than on day 6 can prevent LS surge, particularly in higher ovarian response patient, PCOS patients particularly. So antagonist initiation earlier than day 6 prevents premature LS surge. So whenever we are predicting that these patients can go into premature LS surge, we have to start early antagonist. This is very big study by from Fertility Sterility. They have done on around 10,945 patients, poor responders, and in that they have added twice daily GnRH antagonist in this type of poor responder to prevent the premature LS surge. And then they found reasonable pregnancy rates were noted. Now, this is the new kit, not exactly new kit. This is the progesterone primed ovarian stimulation. This blocks the LS surge through progesterone instead of traditional downregulation by agonist or antagonist. So PPOS can effectively serve as an alternative to conventional treatment with GnRH. But why it was not used till now? Because it has detrimental effect on endometrium. So it was not used because we were using fresh cycles. One more study, this is very few studies on aspiration of single leading follicle, but I don't know it is very effective or not. And when there is one follicle is leading, then we can aspirate the follicle to prevent the premature LS surge. So PPOS, now we are having frozen embryo transfer, so we can go for PPOS cycles. One more indication in a donor cycle, use of clomipene citrate prevents premature LS surge during COH, and this study was done in Sames Hospital on 150 around 120 donors, and they used clomipene along with this GnRH for stimulation in oocyte donor programs. This is also novel GnRH antagonist protocol by switching to medroxyprogesterone. In this, instead of GnRH antagonist, after 3 days of antagonist, it was switched to medroxyprogesterone acetate. And the study first demonstrated that antagonist could be switched to MPA and effectively prevent LS surge in patients at a high risk of OHSS after an average of 3.1 day. So this can be effective tool for preventing premature LS surge. One more thing, latest is mifepristone in long protocol with GnRH agonist, mifepristone 40 milligram. But simultaneously, you have to start with 50 milligram progesterone at the time of STG administration. Mifepristone is effective for prevention of premature LS surge, and but the impact of IVF outcome is controversial. So more studies are required on this. This is also very interesting article on aging-related premature luteinization of granulosa cells is avoided by early oocyte retrieval. So in elderly women, the follicle retrieval, rather than going after 18 millimeter, they started doing pickup whenever follicles are more than 16 millimeter, and they found that it is giving a respectable clinical pregnancy rate in elderly women. So this can be a tool. So now PPOS, Latros, clomiphene can be effective tool. So cat can do anything, can have alcohol. It is not going to damage her liver. There are certain ESHRE guidelines, and I'm not going through it because we can see it online. So for prevention, mild stimulation is very important to prevent LS surge. Latros in stimulation regime, little bit not so exactly said. Use LH with RFSS stimulation. Use of low dose SCG alone in late stimulation. Flexible antagonist and twice daily antagonist. Switch protocol. Add MPA whenever you are planning for frozen embryo transfer. Use of mifepristone. It is very recent. Some more studies we have to go through. And SCG administration when the level of progesterone is more than 1.2, and aspiration of a single leading follicle may be an effective tool to prevent the LSS. So thank you so much for patience hearing.
Thank you, madam, for such a crisp lecture. Madam, there are some questions are coming. I'll just copy and forward you. So without wasting time. So you can, if you want, you can answer in the chat box also. So
Okay.
now let's, yeah. Madam, will you
So
please
you're
stop sharing
forwarding
the
on?
screen? Yeah. Yeah. So now we all are eagerly waiting to hear Dr. Shivani, a very important topic. A lot of doctors are having a lot of queries related to that. So yes, over to you, Dr. Shivani. Once again, warm welcome.
Thank you very much, Dr. Ritu and Sheel and everybody who is here for being with us today. And Dr. Ritu is like most wanted. I mean, it's a big celebrity status to be on her program. So we are really very happy to be here. Me and Neelu and of course everybody. Now,
I am with the stalwarts. I am with the stalwarts.
so let me start the presentation. 1 minute. Actually, इतने सारे PPTs हो गए हैं वो.
Brijbala madam, that all are the appreciations. Sorry, not the questions. On the YouTube, I received all appreciations. Till now, no
I was
questions.
looking for questions. Okay, you can share.
No questions.
Yeah,
Later on, I
1
will
minute.
share the link of the YouTube also with all of you. Yeah.
Okay, so I got it now, and 1 second. Sorry, just hang हो गया 1 minute. Okay, finally. Yes. Right. So let me do screen share.
Dr. Shivani has moderated a panel on this in the Bhubaneswar ISAR, which was highly appreciated by all. So I requested Dr. Shivani to please take here so everybody can be get the benefit. Those who are not able to come there, those all can be benefited by this. Yeah.
Yeah,
Over to
so
you.
thank you so much for this opportunity. And it is often said that takes a village now to raise a child. In today's ever-changing world of IVF, it can justifiably said that it takes even a village to have a child. Reproductive endocrinologists, embryologists, genetic counselors, nurse, obstetrician, and now add lawyers too. So we know that there are new laws which have come, they continue to develop, evolve. So now, in addition to science, as Dr. Brijbala has told us a lot about science, we need to know something about the law also. So currently, as of now, we have 4,993 clinics that have applied for ART registration and 361 only have been registered. 1,300 ART banks have applied in the country and 900 clinics have only applied for surrogacy. So my first point today to everyone is, do you feel that your practice has changed significantly after this ART Act was passed? See, what happened was that infertility increased so much that the number of infertility treatments was increasing, and there was a need for accessible, available, affordable ART practice. And probably that is one of the main reasons why this ART Act was passed with 6 chapters. Now, there are mainly three levels of regulatory authorities over us. The first is the National Board for ART and Surrogacy. The second is the State Board for ART and Surrogacy. And the third level is at our local level, which is our appropriate authority. Then there is a national registry also, where we will have to submit all the data. And as of now, 26 states, union territories have notified the appropriate authority. And what is there you see in this slide, very busy slide, is the number of amendments or the number of gazettes that have come after the ART Act was passed. So there have been so many new notifications. Now, this talk is going to be very, very practical for us, that what we are seeing in practice and how we are dealing with it. So first of all, a couple in your neighborhood. Now, all of us may not be registered as IVF doctors. All of us don't have a level 2 clinic registration. So if you have a couple who has come to you for infertility, can you start counseling them? Can you start doing their investigations? Do you need like a level 1 or level 2 registration for this? This is the most common question asked. Now, under ART Act, it is very specific that it is defined as technique to obtain a pregnancy by handling the sperm or oocyte outside the body and then transferring the embryo or gamete into the reproductive system. So it is only IUI and IVF which is included in this. So the answer to my question is yes, you can counsel. Yes, you can do infertility investigation. No, you don't need a level 1 or level 2 registration for doing this. Now, what is a ART clinic? Like you decide, okay, I have some patients not getting pregnant. I want to do an IUI. So I want to know about ART clinic. What is it? So it is any premise which is equipped with the requisite facilities and the medical practitioners registered with NMC to carry out the ART procedures. So level 1 clinic is those where preliminary investigations are carried out, including the diagnosis of type, cause of infertility, and only IUI is carried out as a part of the treatment. Now, there are different states and they are going to interpret this differently. So what has happened in Delhi is that now we have got this query that if you are counseling a patient of infertility, it is genetic counseling. You should fill Form D, but you cannot fill Form D unless you are registered under PCPNDT. So does that mean that all the doctors who are doing any kind of infertility counseling should be registered under PCPNDT? So when I was in Orissa now for Bhubaneswar, Dr. Hara sir, he is part of the State Board of Orissa, and he has said we are very clear that anybody can counsel the patients. You don't need PNDT registration, at least in Orissa. In Delhi, we don't know. Maybe they are going to start this requirement, but that is what we have been informed. But this is something which is very different in different states. So overall, from the ART Act point of view, you don't need any registration just for counseling. Now, what about medication? You have done your investigation. Now you come to the next step. You want to give clomiphene, letrozole, or injections. Do you need any registration for that? So if you want to use induction medication like clomiphene or letrozole, you do not need any registration at all. But if you need gonadotropins, if you are going to use gonadotropin, then it is questionable whether you need registration or not. It depends on your local authority. For example, now take a look at another difficult question. So this is a patient I had in clinic, which is why I've put it up here. 37-year-old wife, 56-year-old husband. Now they have come to me that they want infertility counseling and they want some investigations to be done for them. Now, as we know, the upper limit for ART is 55 years for the male. But here I am not doing any ART treatment for them at all. So they are not coming under the ART Act. So this is just to emphasize that just for counseling and for doing investigation, you do not need any registration. So don't be worried about from that point of view. Now, gonadotropins. There is a RTI. Now, again, I am told by the lawyers that RTI are not very legally solid representation. So there was an RTI which was put to find out if gonadotropin can be used by somebody who is not registered under ART at all, any gynecologist. So the answer was that they expect gonadotropins to be used by gynecologists that is registered under ART. But as we know, RTIs don't have that strong legal validity. So a level 1 ART clinic, just for information, is a clinic where there is only IUIs carried out. Some states may want, if you're doing gonadotropin, because there is risk of OHSs, that you register under ART. But however, currently for us, we don't need registration to give gonadotropins. You can prescribe injections also. Now, what is the staff requirement for a level 1 clinic? One gynecologist. What is the requirement for the gynecologist? That they should just be postgraduate in OBGYN. They need one microscope, one centrifuge, and one refrigerator. 3 things, and registration of 50,000 for 5 years. You will be so surprised to know. I'm sure you all agree with me that we are doing at least 5 times or 10 times the number of IUI as compared to IVF. There will be maybe 2 lakh IVF cycle or 2.5 lakh IVF cycle in the country. There will be many more IUIs. But level 1 registration clinics are hardly any. Hardly, I mean, just so few, less than 1/5, because maybe it is so cumbersome. People are afraid, they don't want to get registered, and many people, maybe going to a level 2 clinic even just to do their IUI, or must be doing something else. So it is really eye-opener even for the authority, because I was there with one of the state authorities in Bhubaneswar, and they were saying it is an eye-opener for us that people are not registering only as level 1 clinics. So possibly there is some problem there, and maybe we need to make the requirements for level 1 clinics simpler, or maybe make some changes. Then what about level 2 clinic? Now, level 2, you need gynecologist, anesthetist, embryologist, counselor, and additional staff at the level of director and andrologist may be employed. You don't have to have this mandatory. You can have somebody who is either part-time or just on a visiting basis. So now you are a gynecologist and you are thinking, maybe I will go in infertility practice. I want to do some training. So what are the requirements that you should bear in mind? You should bear in mind that a gynecologist who wants to do level 2 practice, which means IVF in our country, or even if you want to just do stimulation for IVF, even for that, they are very clear that you should be in a level 2 clinic when you're doing stimulation. You should be a postgraduate in OBGYN. You should have at least 50 egg pickup procedures and 3 years of working experience. Now, if you are a super specialist in DM or fellowship in reproductive medicine, so sometimes the fellowship is only 2 years, whereas they specify 3 years. So you have to remember that this 3-year criteria has to be fulfilled. Now, gynecologist who is taking a patient to another clinic, what is your qualification? What is your registration? Do you need a logbook? Do you need PNDT registration? Do you need competence in ultrasound? What do you need certification? So here, if you are taking your patient to an ART clinic, then you can either register, your name must be registered by that clinic. So that clinic has to send your documents for registration. And you need to fulfill, if you are going to do level 2 practice, you have to have those 50 egg collections and all the criteria. Otherwise, the patient should be under the name of the ART specialist who is fulfilling all the criteria, not under your name. You need logbook for all that. We need PNDT registration also, which your ART center, means wherever you are taking your patient, they will do it for you. And competence in ultrasound. Unless you're not competent in ultrasound, you cannot get a level 2 gynecologist registration. So that is also required. And basically a gynecologist should, these are all the requirements, knowledge in the principle of ovarian stimulation. Competence in ultrasound is a must. Now, of course, we know that you cannot establish a bank or a clinic or any other setup unless you are registered. So these are the practical points. There was somebody who had made a summary, and I've taken it from them, these practical points that check if you're running a ART2 clinic, how many gynecologists, what is their registration certificate, experience certificate, and indemnity. Now, role of embryologist. Very few people talk about this. Junior embryologist, graduate in life science, biotechnology, reproductive, veterinary science, or postgraduate in life science, biotech, reproductive science. And senior embryologists, the biggest problem that they had was this on-site registration, that most of the people had done some online classes and they were not on-site. So as a one time, they had said that, okay, we accept the registration of all the embryologists. So, but any new embryologist who comes are going to have to fulfill this on-site training of a PhD or a postgraduate degree. And these are all the duties to ensure all the equipment and the procedure and maintaining all the records. Now, there is a question, should you have visiting embryologists? Is it okay? Do you need in-house embryologists? So this was clarified that there is no restriction on how many centers an embryologist can visit. Embryologists can visit as many centers as they want. But if there is an inspection, like at your place, maybe it is surprise, maybe it is planned, at that time, your embryologist whose name you have submitted should be present if there is any procedure which is going on. So there is no limit for the embryologist, but you must have a document signed from the embryologist that they are going to be available for you. Now, again, in the Act, it says that the trying to conceive. I mean, how do you define infertility? So if a couple has come to you, they're trying to conceive only for 4 months or 6 months or 8 months. So can you do their tests? Can you do investigation? What will you do? You will tell them to wait for a year. So definition of infertility in the ART Act is 1 year of unprotected coitus, but it is also proven medical condition. So I think you should start the investigation, because if your patient has something like premature ovarian failure, polycystic ovary, or an age factor, then you should not be waiting 1 year. But bear in mind that the woman has to be, if you're planning ART, she should have completed the age of 21. If the ID proof is wrong or the age is incorrect or whatever, do not start any ART until she is 21 years of age. You can do investigation. You can give treatment in the name of PCOD or endometriosis or any other condition like that, but not do ART. Then cryo shipment of embryos. So many questions. I'm telling you, after I've given this presentation, I have so many questions, because hardly, you will not believe, maybe 5 or 10 clinics in the country have been successful in doing cryo shipment of embryos. And the whole process has now become a little tricky. So this is how it is done. First, the patient will contact the clinic where the embryos are stored and where they want to ship. Contact at this national board at SN Jasra, complete and something called Annexure 4. Then complete an affidavit and Annexure 4, which has to be notarized on 10 rupees stamp paper. Send all your documents to the National Medical Board at this SN Jasra mail ID. It takes approximately 2 months. And you have to send it by email only. And this is the format of the documents which are given. These are the affidavits that you have to sign. And this is kind of the certificate. Literally, they give you a certificate. You think you have won something big. It's a victory, because you feel you have been successful in shipping the embryo. So this is the kind of certificate. Now, what is the maximum time that you can keep it frozen? It is 10 years. Can it be extended? Yes, definitely. You can write to the board and extend it. Any mandatory test before cryopreservation? No, nothing is written as mandatory. It is up to you, but it is, of course, advisable to do all the STD screening tests. Now, definition of commissioning couple. What is a couple? Any married couple. So you please note that they have to be married if you want to do ART for them. So essentially, let's take a look at what has happened to IUI treatment after this act was passed. First, age criteria aa gaya, only 21 years. Qualified, that means only a postgraduate gynecologist should be doing this. Your place has to be registered, the personnel has to be registered, you have to display your registration, renew the registration, documentation, you have to fulfill everything, benefit. Maybe there is benefit to the patient that now there is, strict level at who is doing, and counseling is mandatory about ectopic pregnancy, OHSS. Costs have gone up. This is a big problem. That basic premise of IUI, which was a simple, affordable treatment, maybe that is lost, getting lost somewhere. And complication can happen to anybody. I collected 5 eggs, my patient had severe OHSS with fluid ascites on her way to the airport, and she had to cancel a flight. So complication can happen anytime. So it is very stressful for the doctor, and maybe that is why people are just not registering level 1 clinic, because they think it is not worth the bother. It needs really simplification. And are there any mandatory tests? As I mentioned, there is nothing mandatory. Mandatory is only for the donor, and that is also HIV, Hep B, C, VDRL. Those are the only tests. So my question to you is, should all gynecologists get attached to ART clinic if you're doing infertility practice? I think it will be a good idea to do that, so that you don't have to lose your patient. You say, oh, should I do IUI, not do IUI? Sorry, I have to abandon you in between. So it is best you must get yourself attached to an ART clinic. Now, little bit about PGT. So you have 37-year-old female and male. They have child born with cleft lip, cleft palate. They want to do PGT. So what is your suggestion? Or somebody with 5 failed embryo transfer. Now they have embryos which are remaining and they want frozen embryo transfer. Will you do PGT? So PGT has now been limited to screening the embryo for known pre-existing heritable or genetic diseases only, or there is a national board can lay down other condition as it deems fit for pre-implantation genetic testing. So you see, my question was very specific about cleft lip. Be very careful. Cleft lip is not something we can detect on PGT because it may have multifactorial origin. So before we are doing PGT testing, we must tell the patient that, look, it will not detect multifactorial condition. And this is very critical that you give all this information. It is mandatory as per law. So at our place, we are getting all these consents signed. We have this information document that the embryo will need to be frozen and vitrified, may not be suitable for biopsy. You can have inaccurate results. There may be contamination, software error, and of course that we will not do sex selection and chance of live birth rate. And we must also have the consent that research, we don't want to give for research, consent about the fate. If the embryo comes back as damaged, then it is going to be discarded. So get this signed beforehand. Give information about amniocentesis, NIPT, that they are the alternatives which are available. And again, this patient in my OPD, 2 healthy female children, 1 abortion at 12 weeks. They say, we don't know the reason. Now they want to do PGT. So, of course, these are the cases where we would be very suspicious, and probably we would not, I have said, unless we don't have some genetic report as to why there is a miscarriage, we cannot go for PGT because you've had 2 healthy children. But you do get questions like that. Now, gamete donor, just a line about this. Because in this presentation, it was getting too long. So I have not gone really into donor sperm and donor egg, but it is just somebody who provides sperm or egg with the objective that they should have a child. Last 2-3 questions. So gynecologist who's doing screening for ART, say a patient comes to Dr. Ritu and says, ki, this is my egg donor, Dr. Ritu, can you please check her and tell me if she's okay to be taken as egg donor, or can you just do her follicular monitoring? Is this allowed? Yes. Even if you're not registered as level 1 or level 2, it doesn't matter because you're not doing any ART. You are just doing her screening and just doing her ultrasound. So that is allowed. Now, we will skip all this about duties of ART clinic. Now, the reason why I have mentioned this is, please note the age for women 21 to 50 and for man 21 to the age of 55. And you must have a document where you mention. So I have taken one from Dr. Hitesh Bhatt and Geetendra, where they have mentioned about all the complications, including even the risk of death of the patient. in IVF, because now we have to have very detailed consent signed by the patient, and grievance cell, most important, please have it in a very prominent place in your clinic. Offenses and penalties, of course, I will not go too much into this. The first one is fine, and then there is imprisonment. And we are not, they are writing that you should not exploit a couple woman. I mean, of course, no doctor will ever want to do anything like that. Now, OHSS, somebody has landed in OHSS. Can a gynecologist look after her? Yes. A couple comes to gynecologist for screening of potential surrogate mother. You don't need any registration. You can do the screening. What about antenatal care and delivery? Should your hospital be registered under the Act if you want to deliver surrogate mother? No, it is not required. These are some of the consent forms which all have to be filled in each of the situation. Post-mortem sperm collection, this is something that is addressed in this ART Act, and it is a really welcome step that if the patient has given consent before, it can be done. Fertility preservation, whether it is social or oncofertility, has been addressed. So we are very happy about that. Insurance is provided only for the donor and surrogate. There is a great need to provide insurance for IVF that will boost the IVF treatment in India. So that has not been addressed. We feel that that has been let down. Altruism. Now, this whole concept that donors and surrogates are altruistic, really, how much is that applicable? We don't know. At least for international patients, we are allowed to do IVF, so tourism left open. And social stigma, I think that according to me, there should have been a specific line that any woman who's not able to conceive or does surrogate, you should not use bad words like renting a lady or renting a woman, and all these kind of words should not be used, and they should have actually put it in the Act, because Supreme Court has mentioned it, that you should avoid using unpleasant words like that. And I'll skip the guideline. Last slide, survey results. So Dr. Jaideep Tank, who's our president, Foxy, has done a survey for the ART Act. And what the survey said was 86% gynecologists said, yes, we wanted the Act. It was welcomed by the healthcare providers because it fills the regulatory vacuum and takes away a stigma that we are a lawless group of doctors. But doctors are not sure if it is fulfilling the aims and objective, because the cost has gone up, the length of treatment has gone up, third-party reproduction, donor and surrogacy very badly affected. Heavy penalties are really crushing the minds of the IVF specialists. We are hugely concerned about all these things, criminal proceedings, and practically nobody can think, even dream about doing research, because there are so many restrictions over there. And it has not made any impact on adoption. Our patients who are not able to do surrogacy here, they have spent 85 lakhs, 1 crore in Kazakhstan, in Georgia, do surrogacy there. So it is not like they have gone for adoption. So really, from our point of view, a very balanced and honest opinion we should always strive to give all our patients. Change is definitely inevitable and our growth is optional. So thank you everybody for a very patient hearing. And thank you so much, Dr. Ritu, for giving me this opportunity.
Thank you, Dr. Shivani, for clearing so many doubts. A very excellent presentation. You have cleared so many doubts. Thank you so much. So now first we will go with the lecture of the most awaited lecture, last but not the least, Dr. Kiran Madam's lecture. Shivani, we are getting a lot of compliments here, and also you can see Dr. Jagjit Singh has joined.
Thank you so much, Dr. Jagjit.
Warm welcome, Kiran Madam. So we all are eagerly waiting to hear you regarding the adolescent contraception. Over to you, Madam. Sorry.
Can you see my screen?
Yes, ma'am, we can see your screen, but the PPT is not there.
Now?
Yes, ma'am. Perfect.
Okay. Thank you, Dr. Ritu. And after I'm very happy to listen to Dr. Shivani and Dr. Brijbala. Very good lectures they have given, and thank you very much. And regarding my topic, it is adolescent health. And the healthy families, they are created by choice and not by chance. So the adolescent age group is from 10 years to 19 years as per WHO, early, mid, and late adolescent age. And we need to think whether the adolescent, they have sex or they need contraception, and what should be the method of contraception for our adolescent. And what does this law says about the sexuality of our adolescent girls and boys, and what is the status of abortion in our adolescents. Unintended pregnancy is a great challenge in our developed country and both developing country. Approximately 16 million births take place in adolescent age group. 3 million adolescent girls, they undergo unsafe abortion. 49,000 of the adolescent males and 46,000 of the adolescent female, they are HIV positive in India. So the adolescent-friendly health services is of utmost importance for avoiding these unwanted pregnancy and sexually transmitted diseases. India being a young country, and females, they marry and have sex at early age as compared to the males. So the non-use of contraception can lead to teenage pregnancy, maternal mortality, unsafe abortion, preterm delivery, and neonatal complications. Contraception knowledge is quite high in our adolescent now, but still the unintended pregnancy and unsafe abortion, they are quite common because approximately 18% of the teenagers don't use contraception, and 50% of teenage pregnancy occur in first 6 months of initiating the sex when they are not knowing about the side effects. So they land up in unsafe abortion and sexually transmitted diseases. The knowledge about contraception is related to the level of education, socioeconomic status, marital status, urban versus rural class, and working versus non-working class. So the contraception counseling in our adolescent and POXO Act, there are two conflicting situations in India. POXO Act says that sex before the age of 18 years is a rape, even if it is with consent or with marriage also, and it needs police reporting. So the adolescent contraception counseling and prescription is questionable in the minds of Indian medical professionals and educationists. In a survey done in 118 districts, it was found that 10% of the adolescent pregnancy was noted in certain states of Bihar, Jharkhand, West Bengal, UP, and Rajasthan, and 20% of the girls, they were marrying before the age of 18 years. Counseling in adolescents regarding contraception is a crucial thing, and we should strongly encourage them to postpone the initiation of sexual activity. ABC strategies is to be followed: abstinence, be faithful, and use contraception. Counseling includes the selection of method with least possible side effects. Tips on adherence to the contraception should be given, and we should emphasize upon the use of barrier methods, and dual protection method is to be used. Emergency contraception, we should give them practical suggestion that they should keep the emergency pill and condom in their purse, and all these things should be done in a non-judgmental, friendly, and confidential manner. Our aim is to prevent the unwanted pregnancy, sexually transmitted diseases. All the contraception that fall in WHO MEC 1 and MEC 2 category, they are all suitable for our adolescent girls and boys, and with emphasis on the dual protection. Careful history should be taken, and we should rule out the medical illness, and we should provide them the educational material for contraception based upon the needs of the adolescent. We should make a well-informed and shared decision regarding the contraception choice. These types of charts, they should be available in our OPD or outside our OPD, or whenever we are conducting some camps for the adolescent health. So that they can go through these charts, and they can know what are the methods available and where they are being used. All these counseling should be done in a very non-judgmental way, and we should take about the medical history, sexual history, reproductive history, any history of abortion. What does their pocket allow for the contraception? Whether they want to hide from their parents or from their partner about the contraception, and what is their knowledge about the sexually transmitted diseases and contraception. We should all ask this, and we should tell them the non-contraceptive benefits of the OCPs, and we should tell them about the importance of follow-up. So the condom from any other method of contraception is ideal for our adolescent as contraception. And male condom, we should tell them how to use it, how to throw it. And this can be done by using the YouTube links or sharing videos or demonstration on some models. Vaginal spermicide, it is not a method for contraception, not a preferred method of contraception for our adolescent because it can irritate the vaginal mucosa. They can make the young woman prone to the HIV infection. So the CDC Atlanta, USA discouraged the use of vaginal spermicide for preventing these sexually transmitted diseases and the HIV protection. The hormonal contraception can be in the form of tablets or injectables or ring or transdermal patches. Non-contraceptive benefits of the OCPs to the adolescents, they should be told, so they will adhere to the contraception after listening to the benefits of the non-contraceptive benefits of the OCPs. DIMPA is injectable form which is to be given every 3 monthly. But our main concern is that it may interfere with the achieving the peak bony mass, especially in the very young adolescent girls. The Society of Adolescent Health and Medicine, they have suggested that duration of DIMPA may not be restricted for 2 years and BMD monitoring is to be individualized. They emphasize on the calcium, vitamin D and exercises for our adolescent when they are using this DIMPA. Some of these say that if the patient is satisfied with the DIMPA and the patient is at risk of osteoporosis, they can use the estrogen practically, but it is not being done so. Nova ring, it is a vaginal ring, soft silicone ring. It has got 99% efficacy. It is used in girls who are using menstrual cup, and it is to be seen that it is not removed for more than 3 hours in 3 weeks' time for cleaning. And the repeated cleaning leads to the loss of efficacy and intermittent bleeding also. Transdermal patches, they require weekly change and they can be initiated as a quick start method. LAG method, that is IUCD and implant. The ACOG recommends IUCD as a first line contraceptive along with the implant, and the non-touch technique of insertion of IUD. Availability of sleek IUD, there is less pain, less infection, and there is no effect on the future fertility of the adolescent girl. And the IUCD is only contraindicated if there is current PID, purulent cervicitis, or there is PID in the last 3 months. The implants, they have got 3 years efficacy. They need insertion and removal, but it has got no effect on BMD. And the pregnancy is to be excluded before insertion. And it is not a method of quick start, but it is a quite useful method because once inserted, the patient can get the benefit. So the adolescent, they are more likely to choose a LAG method if they are consulted properly. CDC, ACOG, and American Academy of Pediatrics, they all recommend LAG as the first line option for our teens. Emergency contraception is used in cases whenever there is unplanned sexual activity, slippage of condoms, missing of pills or rape. But it is not to be used as a routine method of contraception. And whenever we suspect there is post-exposure prophylaxis for the HIV, we have to give the risk. We have to do the risk assessment. We have to give the first aid to the patient, and antiretrovirus is to be started within 72 hours till 28 days. That after that, HIV testing and follow-up is needed. The barrier to the contraception are reluctance to acknowledge the sexual activity by the adolescent, lack of knowledge, lack of awareness, misconception, unplanned sexual activity, confidentiality issues, and lack of training of the healthcare providers, financial issues, and the time of clinic hours not matching with the adolescent need, and the judgmental attitude of the healthcare provider and the personal avoidance on such difficult topics. So these barriers, they can be overcome by adolescent-friendly health services and the effective counseling. And it has been seen that the unintended pregnancy, they significantly decrease if the proper counseling is done. These are the barrier to all contraception, that is law, policy, gender and social norms, misconceptions, financial barriers, lack of privacy, and provider bias. So there should be proper systematic approach to, there should be good health information system, service delivery system, and they should be access to the essential medicine. Health workforce should be competent enough, and there should be financing from the government, and there should be on the part of adolescent, there should be they should come forward for this. And the United Nations WHO recommend family planning. They promote the gender equality, autonomy of the woman is to be seen, and there should be informed choice, privacy, and confidentiality is to be maintained, and there should be access to the method, and the evidence-based contraception should be provided by the competent healthcare providers. Choice projects recommend that there should be free contraception services for our adolescent to reduce the teenage pregnancy. If the cost factor is removed, majority of the adolescent, they will opt for the LAG method, and all these should be done in the gather approach. So National Family Health Survey 4, they have seen that although the age of marriage is above 18 years, still many of the girls, they are getting married, and there's low prevalence of contraception methods and unmet need of the high unmet need of the family planning method for our adolescent girls and boys. So new programs have been launched to increase this uptake. That is the designated as counselor, Nai Pahal Kit and Prachar program. So Nai Pahal Kit is to increase the contact between the healthcare providers and the adolescent girls and boys. Prachar program is by Bihar government to create awareness to it is to delay the pregnancy, first pregnancy, by awareness by the media and healthcare providers. So there is role of society, healthcare providers, role of media, and open and friendly attitude of parents and teachers. There should be sex education programs in the school, and comprehensive sexuality and the life skill education should be integrated in the school curriculum. So the Family Planning Summit 2017, they recommend that there is role of local community representative to solve the myths and to improve the quality of family planning services and counseling. And these interventions should be at level of health system, community system, and the adolescent level. And the contraception, they should be free of cost, non-judgmental attitude of the counselor, and it is going to prevent the physical and mental trauma to our young adolescent. Thank you.
Thank you, madam, for such a crisp lecture. Thank you. Thank you so much. You have covered
Thank you.
each and every point. Friends, I've got a message from the Shield Pharma that there is some network issues coming. अभी वो कभी भी collapse हो जाएगा, मतलब उनका overburden हो गया है. So before we wind off, sorry I can't take the questions, friends. There is some technical issues. So we want to take some concluding remarks from Dr. Seema. Dr. Seema, are you there? Till now, I have not received any questions here. Only the appreciations I am receiving. Seema, are you there? You're muted.
Yeah.
Yes, Seema, Dr. Seema, some concluding remarks from your side.
So all the three topics covered today were of real importance, and especially this ART Act and adolescents, contraception and sexual needs. These are the topics, like burning topics, especially adolescent contraception is a topic which we hardly talk about. And we have to be open as a society that things are changing, and these kids, they need to know the right and scientific way to go about it. So it is need of the hour. And Dr. Shivani, the way you have dissected the whole ART Act, that was commendable. And I was seeing you were not looking at your slides, you were just speaking. And that is the weakest area for me. I keep listening kitni bhi baar, n number of times, but every time when I try to just think about it, I cannot do it. You are perfect. And Dr. Brishbala, LS surge, premature LS surge, that was an excellent lecture. And whenever we are doing IOI with more than 2 follicles, premature LS surge is a risk factor, and 30% of our IOI cycles suffer because of those. And if we take a time bound intervention we can save those cycles and we can improve our IOI success. And as Dr. Brajbala said, that for people like elderly, short follicular phase, low ovarian reserve, PCOS, all these people, they need to get a very tight premature LS surge prevention. LS surge per se is not the culprit. The culprit is premature luteinization or progesterone rise. And that is basically happening because of the conventional protocol where our friends, they don't realize when they are using the gonadotropins in international units. Regarding this PPOS, I'm doing a lot of PPOS nowadays, progesterone primed stimulation. And in fact, what I have realized, especially in hyper responders and donor cycles, that the kind of LH protection and premature luteinization, this small tablet prevents. It is not done with antagonist as well, as we all understand that around 20% of cycles where we are adding antagonists, especially in flexible protocol, they are spared and they get premature LS surge. So it's a good protocol, friends, very patient friendly and even doctor friendly. You don't have to do the scanning and everything. You don't have to decrease and increase the doses on every day or alternate day basis. So all the topics were really pertinent and well taken care of.
Thank you,
Cheers for Dr. Ritu and team for collecting stalwarts from the field and getting people, like as you shared, knowledge is for sharing, but there are very few who does it the way Ritu does.
Thank you, Seema. Thank you, my all the three esteemed speakers, and big thanks to Dr. Seema also. I am following the Seema since I can say more than 7-8 years. So when
we
I
are,
started saying
I will
we are,
stop Ritu
let
and I'll
let
say
me
we are
share this. Let me
self-admiration
share.
society.
Let me share this, Seema, because that time I met Seema in the forum, the Ops Gynec discussion. So I asked Seema some questions. I'm really thankful to her that in spite of her busy schedule, she always gives the answer. There are two persons. One is the Dr. Monica Chawla. I can say मैंने उनका इतना दिमाग खाया होगा डॉक्टर मोनिका चावला का जितना मैंने किसी का भी नहीं खाया होगा. Every day I asked her a bombardment of the questions. And she always replies me, मतलब she always tell me how you are getting so many questions, कहाँ से तेरे दिमाग में इतने question आते हैं. तो always she replies. And yes, really I'm thankful to you, Seema, also. Thank you, Brajmala madam. Thank you, dear Shivi. Thank you, Kiran madam, for such an excellent deliberation. सॉरी फ्रेंड्स, देयर इज सम टेक्निकल इश्यूज. अभी कुछ क्वेश्चंस आने शुरू, लेकिन बार बार शील फार्मा की तरफ से मैसेज आ रहा है मुझे वाइंड अप के लिए. ऊपर देखिए लिख भी रहा है प्रिपेयरिंग लाइव स्ट्रीम, तो सम टेक्निकल इशू. So with this we will wind up, friends. Thank you, bye bye, good night.
Thank you,
Bye.
Ritu.
Bye,
Thank you, Seema,
everyone. Bye.
Shivani, and
Bye.
Kiran madam. Thank you so much for meeting on this webinar.
Bye everyone. Bye bye bye.
Bye bye, sir. डिस्कनेक्ट नहीं हो रहा है मुझसे. हाँ, साहिती, it is not disconnecting. I don't know, it is hang. उसको सेव तो कर लो, इतने अच्छे लेक्चर्स हुए.